discussion about Hill-Sachs lesion and the glenoid bone loss, how to measure them, concept of on-track and off-track morphology, what exactly it is, soft tissue Bankart lesion or labral tear, and a short discussion about the capsule, which is often repaired by orthopedic surgeons. So whenever I see a case of shoulder instability on an MRI, this is the reporting format that we usually pick up. On the humeral side, we obviously look at the Hill-Sachs lesion. On the glenoid side, we assess the bony Bankart lesion, glenoid bone loss, soft tissue Bankart lesion, and chondral injury, which is also called as GLAD. Measurements, we take the glenoid tract and Hill-Sachs index. So these are the two measurements besides the glenoid bone loss that we take in any patient with anterior instability. And this is how we get an idea of on-track or off-track morphology. By on-track, I mean that it is not going to engage. By off-track, I mean that the shoulder is going to engage. Then next is we discuss about the capsule or the inferior glenohumeral ligament. And finally, we also mention what is the status of the coracoid process, because if the glenoid bone loss is high, orthopedic surgeons consider a Latarjet procedure for which they take out the coracoid process and fill in the glenoid defect. This is an axial proton density image. As I told you, PD image is the backbone of MSK imaging. So both of these are proton density images. So this is an axial image showing the humeral head. This is the glenoid. And what you can see is a defect in the humeral head superiorly. Now this is something very important to understand, that the defect should be seen in the superior-most sections on an axial image. As you come slightly lower at the attachment of infraspinatus, there is a normal defect which is present, which should not be mistaken for a Hill-Sachs defect. So if you see a defect in the superior-most axial sections, superior 1 or 2 sections, that is when you label it as a Hill-Sachs lesion. So this is my Hill-Sachs lesion, and this is how I'm going to measure the length or the transverse dimension of the defect. Similarly, this is the sagittal image. By sagittal image, I mean that the scan is taken from the lateral aspect of the shoulder, and now we are going medially. So that is what is the sagittal image. So this is the Hill-Sachs lesion on the posterior superior aspect of the humeral head. Important is glenoid, because again, glenoid bone loss requires Latarjet or those procedures. So normal glenoid has something called as an avocado or a pear-shaped appearance, where you can see that the antero-inferior glenoid is smooth and round. Okay, this is the 3D image showing that the antero-inferior glenoid is nice and round. Now this is a patient who had a glenoid bone loss. If you can see, even on an MRI, it is blunted. So there is blunting of the antero-inferior glenoid, which means that there is a glenoid bone loss. On a CT image, you can clearly appreciate that the roundness of the glenoid, the antero-inferior glenoid, is no longer present. There is a proper discrete glenoid bone loss, and if you can appreciate, there is a small bony chunk which is present slightly more medially, which is nothing but the medialized osseous Bankart lesion. Next patient, you can see clearly I've labeled with the green and yellow arrows. Clearly there is a glenoid defect, and which can be even appreciated very well on an MR. But the only thing with an MR is, in MRI we take 3 millimeter thickness sections. One of my section has to cross through the glenoid articular surface. If that does not happen, I will never get an accurate glenoid bone loss on an MRI. So that is something that we need to inform our technicians, that we need an accurate section along the glenoid articular surface. So this has a proper glenoid defect, and there is a osseous Bankart lesion as well in this patient. On the axial images, you can see this is my glenoid articular surface, this is my osseous Bankart lesion, and there is a step. So the osseous Bankart lesion is medialized, that is, it is more medial now, and it is not congruent with the glenoid articular surface. So practically, it is not providing any surface for the humeral head to rotate on. So this is my end-face glenoid, or as you see the glenoid end on after you remove the humeral head. So this is my glenoid articular surface, and this is the osseous Bankart lesion. A 3D image to show you the glenoid articular surface, and what you see over here is the osseous Bankart lesion. But this Bankart lesion is large, but it is medial now, and so it is not going to help the humeral head in articulation. So here you can see an oblique image where you can appreciate that my glenoid articular surface is more lateral and my Bankart lesion has gone more medial now. How do I calculate a glenoid bone loss? So the most common technique that is used is the best fit circle method. Now what is this method? So here you can see this is a normal glenoid with a complete nice round anterior-inferior aspect of glenoid. The best fit circle method is nothing but drawing a circle such that it should trace along the posterior and inferior aspect of glenoid. The circle should be made in such a way that it should align with the posterior cortex and inferior cortex of glenoid. After you've made the circle, you have to look for the anterior cortex or the anterior-inferior cortex. And if you see the anterior-inferior cortex is completely aligning with the circle, this means that this patient does not have a glenoid bone loss. A second case, which is the previous one where we saw that he has a proper osseous Bankart lesion, but it is not forming the glenoid articular surface anymore. So excluding this osseous Bankart lesion, I have again drawn a circle along the posterior and inferior cortex. Now one thing which can be confusing is, if you can see there is mild amount of extra osseous bone in the inferior side, which is some amount of osseous remodeling. That osseous bone should not be considered when you're drawing the circle. So this extra osseous prominences should not be considered because they are post-injury changes. So excluding those, I have drawn the circle. Now my diameter of the circle is what should be the diameter of a normal glenoid. But there is a defect, so I measure the length of the defect, I measure the length of the diameter of the circle, and my glenoid bone loss is nothing but, if you can see, the defect is 7 millimeters, which is the small d. The diameter of the normal glenoid should have been 28 millimeters or 2.8 centimeters, which is the larger d. And glenoid bone loss is nothing but small d upon the larger d into 100. So this patient has a 25% glenoid bone loss. And even visually we can see that it is a big chunk which has come out. So what I want to show is you can do these measurements even on an MRI if the CT is not available. But having said that, it is always preferable to get a CT done because it's just one section on which we can measure on an MRI. If by any chance that particular section has not come properly or it's missed, then we are in a soup. So CT is something where you can put it into 3 dimensions, you can play around and you can get the accurate dimensions for glenoid bone loss. Concept of on-track and off-track. The routine terminology that is used in the new articles that have come in is the bipolar bone loss. Bipolar bone loss is nothing but you are evaluating Hill-Sachs lesion, the loss of Hill-Sachs lesion along with the glenoid bone loss. So both of them are evaluated together. Hence it is called as bipolar bone loss. On-track lesion is where the Hill-Sachs is going to be smaller than the glenoid tract. The Hill-Sachs, I'll tell you how to calculate the glenoid tract. So when the Hill-Sachs is smaller than the glenoid tract, obviously the defect of Hill-Sachs is not going to fit into the glenoid and it will not engage. On the other hand, if the Hill-Sachs is going to be larger than the glenoid tract, then it is going to engage. So just a representation diagrammatic to make this more understandable. So when can a shoulder engage? Basic thing, if the Hill-Sachs is larger, it is going to engage. As you can see, this is a smaller Hill-Sachs. The glenoid is normal. This is a larger Hill-Sachs. Again, in this patient, the glenoid is normal, but the Hill-Sachs is larger. And as you can see here, it can actually engage. So this patient, it won't engage, but this patient, it can engage. Second is when the glenoid bone loss is more. Now, both these patients have got the nearly same sized, smaller Hill-Sachs. But here, the glenoid is normal, and here the glenoid bone loss is way too much. Again, it will engage. Now, this is the third one. This is the most important one. Here the patient has a Hill-Sachs with no glenoid bone loss. The patient has a slightly larger Hill-Sachs and a small amount of glenoid bone loss. But when you add both of this together, there is a possibility that it will engage. So this is the concept of bipolar bone loss, where both are not looked at individually, but the defects are put in together and then we make a judgment whether it will engage or not. So for engaging and non-engaging shoulders, what we need is the glenoid tract and Hill-Sachs index. I've already explained what happens when the Hill-Sachs index is smaller or larger. Now how to calculate the glenoid tract? I've already shown how to calculate the glenoid bone loss. It's the same method that we use, the same measurements that we use. Just you need to put it in this formula, where the capital D is your diameter of the circle, which is the normal glenoid it should have been. The small d is the amount of glenoid loss in length, or the transverse dimension of the glenoid loss. So this is how you calculate the glenoid tract. Now it has been postulated that 0.83% of the diameter of glenoid is what is actually supporting the humeral head at any given point in time. That is why it is not the entire diameter, but only 0.3 or 83% of the diameter. How to calculate Hill-Sachs index? Hill-Sachs index is Hill-Sachs lesion with the bony bar between the lesion and infraspinatus entasis. Now, what does this mean? So, this is a patient with Hill-Sachs, where the Hill-Sachs defect is extending up to the infraspinatus insertion. So here in this patient, there is no bony remnant which is present between the Hill-Sachs and the infraspinatus lesion. Whereas on the other hand, this patient has a more medial Hill-Sachs. So as you can see, this is a more lateral and this is a more medial Hill-Sachs, as a result of which there is some amount of normal bone between the Hill-Sachs and the infraspinatus insertion. This is the bony bar. Now, when you are measuring the Hill-Sachs, you're going to measure only this much. But while calculating engaging and non-engaging, you need to add both these up, because the humeral head is going to engage along the medial border and not along the lateral border. So in case of a medialized Hill-Sachs, even if it is a smaller Hill-Sachs, it can engage. So this is how you calculate the Hill-Sachs index, the Hill-Sachs lesion plus the bony bar if present. Just a couple of images to show you soft tissue Bankart or the labral tear. We don't use much of arthrograms because it is not required. If you have high resolution, good quality images, you can appreciate labral tears even without an arthrogram. So here you can see there is a labral tear in this patient. Similarly, there is a labral tear over here. And this patient has got anterior as well as posterior inferior labral tears. So the whole idea to put this is we really don't need arthrograms to identify labral tears, and we can just do it on a plain MRI. Capsular injury is something that you guys need to know for repair. So this is at the humeral attachment and this is at the glenoid attachment. There is inferior glenohumeral ligament or capsular injury. Do we need a CT in shoulder instability? It is not a must, but it can help better in measurements, particularly for glenoid bone loss. It's a good modality to get a 3D view of the glenoid, that is the end-face view that you can see, which is what you'll see when you open up the patient, to look for small osseous Bankart lesions. This is just a format of the reporting that we provide. So this is how we give the entire reporting for any patient with anterior instability, and this is, I guess this will make your jobs for surgery way easier. What have we discussed today? Concept of bipolar bone loss, how to take measurements. CT is not a must, but glenoid evaluation is better with CT scan. Hill-Sachs index evaluation is more accurate with MRI because we can see the infraspinatus insertion, and MRI is useful in assessment of labral tear and status of the capsule. Thank you.